Ni?
No.
So she's there.
Oh,
So
sorry.
she will be presenting paracentral acute middle maculopathy-like lesions associated with ocular and systemic inflammation.
A very good evening to everyone. I'll be presenting a retrospective case series of paracentral acute middle maculopathy-like lesions and Persner-like retinopathy. These are the ischemic maculopathies and their association with systemic diseases. So we have 6 eyes of 5 patients. First case is an 18-year-old female who presented with left eye blurred vision, acuity of 6/9. Fundus showed Persner-like retinopathy with pallid retina. OCD showed band-like hyperreflective lesion extending from the inner nuclear layer to inner plexiform layer and in some areas even inner layers. There was a wavy outer plexiform layer showing segmental thinning of the INL, and even you can appreciate this prominent middle limiting membrane-like lesion, which is an ischemic lesion. FFA showed hyperfluorescence and ICG showed hypocynosance corresponding to the lesions. On evaluation, peripheral smear, echo and lipid profile was normal. However, partial occlusion was noted in bilateral common external and internal carotid artery on Doppler. So in such a young age, we suspected autoimmune pathology and we did a workup. PNK came to be positive, which could be causing the ischemic events because of the premature atherosclerosis. So she responded very well to the oral steroids. Second is a 45-year-old male who presented with bilateral anterior scleritis with blurred vision, acuity of 6/9. Fundus showed again parafoveal whitening. PAM lesion was seen in both eyes on OCT. However, right eye showed coexisting AMN lesion. You can appreciate the ellipsoid zone subfoveal disruption here. Octa showed phlovoid areas in the deep plexus. So considering the inadequate response to systemic steroids which were given elsewhere, history of contact with a pet dog, elevated toxo-IgG titers, we made a provisional diagnosis of toxoplasma-associated anterior-scleritis and PAM. And this time he responded well with oral steroids as we added oral azithromycin monotherapy for 4 weeks. So third was a 22-year-old male with left eye blurred vision, acuity of 6/9. He presented with right eye cotton wool spots. Left eye also had cotton wool spots along with a BRAO and an adjacent white pallid retina. OCT showed PAM lesions again. However, FFA showed hypocynosance and mild perifoveal vasculitis here. ICT showed hypocynosance. So considering bilateral ischemic changes, vasculitis in the right eye, history of recurrent papillary skin rashes, along with the HLA-B51 positivity, we diagnosed him with Behçet's disease, and he showed good response with oral immunosuppressives. Fourth was a 63-year-old female who presented with light perception vision in the right eye, and she presented with Persner-like retinopathy. You can see the pallid disc edema. Fundus showed again PAM lesions. She had significant arthritis and her ANA was strongly positive. So she was diagnosed with the SLE-associated PAM and PLR, and oral steroids were initiated. However, she showed poor response to treatment. Last case is a 21-year-old male with right eye blurred vision, acuity of 6/36, again posterior pole pallid retina with PAM lesions on OCT. He also had arthritis, both rheumatoid factor and ANA was strongly positive. So he was again diagnosed with the autoimmune possibly associated PAM and PLR. He was initiated with oral steroid and had good response. So both Persner-like retinopathy and PAM have known association with autoimmune diseases like SLE and Behçet's. However, we present a unique association with PNK. Autoimmune disorders, including PNK positivity, can lead to premature atherosclerosis in young age and accelerated plaque rupture. And this can predispose to ocular ischemic events, especially in the watershed areas in the retina, that is the posterior pole, and even the cardiovascular incidence. Again, the last case, the toxoplasma also has been associated with scleritis and retinal vascular occlusion in literature. However, in our case, bilateral scleritis with PAM was present. In the absence of retinitis, it is often labeled as idiopathic, but it may represent an atypical ocular toxoplasmosis, a rare association. So in presence of these subtle ischemic insults of PAM and PLR, they are the biomarkers of underlying disease, which could be life-threatening as well as sight-threatening. So this should be treated, evaluated, and early treatment should be initiated. Thank you. These are my references.
Thank you, Dr. Eliza.
Thank you.
So most of your patients have underlying autoimmune disease association.
Did you see the reversal of the OCT biomarker of PAM? If so, how long does it take?
It took, ma'am, except the second last case, the elderly female, she had diabetes also, so IVMP and steroids were given elsewhere. She didn't improve. But all cases improved to 6.6 with improvement of PAM lesion and little thinning of the inner nuclear layer. But the hyperreflectivity didn't go away fully. But there was a mild hyperreflectivity, mainly of the inner plexiform layer, but inal thinning was noted, and it took almost 4 weeks. The first patient, that the young girl, she almost improved in 2 weeks of oral steroid to 6.6 vision. That little bit of scotoma went away with high-dose steroids.
So what the other question is, visual field defects did you notice? And if so, those defects, how long does it take time to disappear?
We had asked the patient 1 week review post starting because I wanted to keep a close follow-up. And all the patients, except that fourth patient, demonstrated improvement in their vision in 1 week. And they improved well, all the four, but the fourth patient did not improve. And she was a
She's
diabetic.
asking about
too.
the visual fields.
Visual fields we didn't do, ma'am, in any of the patients, just the scotoma clinically. We just did multimodal. Fields were not done.
No, fields also another modality in which you can document the scotoma, and we can see, in addition to the OCT, whether the reversal of the scotoma is happening or not.
Yeah. Okay. Thank you so much, ma'am.
Thank you.
Thank you.